Welcome to the deep dive. We jump straight into complex info, pull out what you really need, and get you up to speed fast. Especially if you're an orthopedic resident prepping for those big postgraduate exams, FRCS, fellowships, you know the ones.
Absolutely. It's a huge amount to cover. So our mission in this deep dive is to really zero in on some key high-yield forearm and elbow trauma patterns.
Yep.
We'll unpack the crucial diagnostic points, the classifications, management strategies, and, the potential pitfalls you need to have nailed down.
Exactly. Today we're tackling radial head fractures, the really challenging Essex-Lopresti injury, Monteggia fractures, and Galeazzi injuries. These are true classics, but full of details that examiners love.
And just so you know where we're drawing from, this deep dive is based squarely on the excellent Ortho Made Simple notes. You can find them on the website mokyingren.sg.
Right.
They were put together by Dr. Mok Ying Ren, who's a sports surgeon over at National University Hospital in Singapore. He completed his FRCS back in 2022, so these notes are quite current and exam-focused.
Fantastic resource. So let's do this. We're going to pull out the absolute must-knows from these notes to help you feel ready, whether it's for the exam hall or, that 3 a.m. call. I'm actually quite keen to get into these. They really test how you think about the whole forearm.
And it's more than just exam fodder, isn't it?
Yeah.
Recognizing these patterns quickly, understanding what else might be injured, knowing the why behind the treatment sequence is just fundamental for good patient outcomes. It's about connecting the dots.
Okay, let's kick things off right at the elbow then. Radial head fractures. You see one on an x-ray. What's the first classification system that should spring to mind?
That would be Mason's classification. It's really the foundation here. It breaks them down nicely.
Okay.
Type 1 is basically non-displaced, just a crack. Type 2 is displaced, and the key here is assessing for a mechanical block, does it physically stop movement?
Right.
Type 3 is comminuted broken into multiple pieces, generally meaning more than 3 fragments. And type 4, well, that's any of these fracture types, but with an associated elbow dislocation.
Got it. So types 2 and 3, the displaced or comminuted ones, how do we typically manage those? Is surgery the standard approach?
Well, the notes are clear on this. Or IF, so open reduction internal fixation, is generally the accepted treatment if there's a definite mechanical block. If that fragment is physically stopping pronation, supination, or flexion extension, you've likely got to fix it.
Makes sense. But here's where it gets interesting, and the source points this out. What if it is displaced, maybe even comminuted, but there's no mechanical block? The elbow moves okay.
Yes. This is where the evidence gets a bit murky, and the notes reflect that well. There's actually no consensus on the best way forward in that specific situation.
Really? No consensus?
Not really, no.
Yeah.
The notes mention studies like the CANS 2012 Systematic Review in JHS Journal of Hand Surgery basically found insufficient evidence to say surgery was definitely better than non-op, with similar success rates reported. And then there's a more recent RCT, Mulders et al., 2021 in JSES, which also showed pretty similar functional outcomes at a year for these displaced ones without a block, regardless of treatment. It really shows you sometimes the literature just reflects equipoise.
So non-operative treatment might actually be a reasonable long-term option for some of these, even if they look quite displaced on the x-ray, provided there's no block.
Potentially, yes.
Yeah.
The notes reference the Axon et al. 2006 study from JBJS. They did long-term follow-up, about 9 years, on non-operatively treated radial head fractures.
Okay.
And they found, range of motion might be a bit reduced, but it often stayed within what we consider functional limits.
Yeah.
30 to 130 degrees flexion extension, 50 pronation, supination, roughly.
Wow.
And here's the kicker. 82% showed radiographic signs of osteoarthritis down the line. But crucially, they remained asymptomatic.
Wow. So the x-ray looks bad, but the patient feels fine?
Exactly. It's a classic reminder that we treat patients, not x-rays. Radiographic findings don't always equal clinical problems.
That's a really vital point for exams and practice. Okay, imaging-wise, any special views that help get a clearer look at the radial head itself? Sometimes it's hard to see subtle displacement.
Yes, definitely. The Greenspan view is mentioned. Some people call it Coyle's view.
Ah, a Coyle's view, okay.
Yeah. The technique involves angling the X-ray beam 45 degrees towards the radial head with the forearm in neutral. It projects the radial head away from the coronoid and can really highlight subtle fractures or articular step-offs. Very useful trick.
Good tip. All right, let's say we are doing surgery or RFF. We're using plates, screws. You mentioned the arc of safety. Can you unpack that a bit? What is it, and why does it matter so much?
The arc of safety is absolutely critical when you're plating a radial head. It's basically the safe zone on the radial head where you can put a plate without it banging against the ulna, specifically the lesser sigmoid notch during forearm rotation.
Okay, so it avoids impingement. How do you find it?
There are a couple of ways described. Clinically, you can approximate it. It's about a 90-degree arc on the radial head, located laterally when the forearm is neutral. You can think of it spanning from the radial styloid to Lister's tubercle projected up to the head.
Right.
Radiologically, on a true lateral view, it's the part of the radial head directly opposite the bicipital tuberosity. If you keep your plate within that zone, you shouldn't cause painful clicking or blocking of rotation. Headless compression screws, though, because they sit flush or buried, can usually be placed outside this arc if needed.
Makes sense. Avoid the hardware collision. Now, sometimes fixation just isn't the right answer, especially with those really smashed, comminuted type 3s. When do the notes suggest we should pivot towards replacing the radial head instead?
Yeah, there's a limit to what fixation can achieve. A key paper referenced is by David Rang and colleagues, published in JBJS in 2002. They looked at ORIF outcomes for 56 patients, and they found a pretty clear threshold. If the radial head fracture had more than 3 fragments, the results of trying to piece it together with ORIF were often unsatisfactory. So, seeing more than 3 parts is a strong indicator to lean towards primary radial head replacement.
Okay, 3 fragments equals likely replacement. And when we do replace it, what exactly are we trying to achieve? What function does that implant restore?
Good question. It's not just filling a gap. The replacement serves several key purposes. First, it acts as a spacer, maintaining the radius length while the ligaments, particularly around the elbow, can heal. Second, it provides longitudinal stability to the whole forearm. And third, it acts as an important secondary stabilizer against varus stress at the elbow. So it restores stability in multiple planes.
Got it. Spacer, longitudinal stability, varus stability. Now, doing the replacement itself, any major pitfalls to watch out for during the surgery?
The big one, the absolute main concern highlighted, is overstuffing the joint. Putting in an implant that's too long or too thick, this can cause pain, stiffness, and even capsular wear.
Right, overstuffing. How do you avoid that? How do you size it correctly?
The notes mention 2 main methods. One is based on Athwal et al.'s work from 2010, direct visualization during surgery. You look at the gap in the lateral ulnohumeral joint and size the implant to restore that space appropriately.
Okay.
The other method is using fluoroscopy, the image intensifier. You put the trial implant in, apply a valgus stress to the elbow, and check the joint spaces. The medial and lateral ulnohumeral joint spaces should look roughly equal. If the lateral space is wider, your implant is too thick. You're overstuffing.
Equal joint spaces under valgus stress. That's a good visual check.
Yeah.
What about implant fixation, cemented versus uncemented? And design monoblock versus bipolar?
The notes suggest there's generally no significant difference found in outcomes between cemented and uncemented fixation for the stem, so surgeon preference often dictates that. However, regarding the design, monoblock implants single piece are generally preferred over bipolar designs.
Why is that?
Bipolar implants have been associated with higher revision rates in some studies, potentially due to issues like dissociation or wear at the articulation within the implant itself. So simpler monoblock seems favored.
Interesting. Okay, so radial head fractures can be nasty on their own, but they often don't happen in isolation, right? What's the big associated injury pattern we absolutely must think about and rule out, especially with those comminuted radial head fractures?
Yes, this is absolutely critical, especially for exams and avoiding bad outcomes. You must consider the Essex-Lopresti injury.
Ah, the Essex-Lopresti.
Exactly. The notes describe it as this rare but devastating combination. You get the radial head fracture, often comminuted as you said, plus disruption of the interosseous membrane, that strong ligament sheet running between the radius and ulna, and a dislocation or instability of the distal radial Mittner joint, the DRUJ, down at the wrist.
Wow.
It's called the upper limb equivalent of a Maisonneuve fracture in the notes, which is a great analogy. Injury at the elbow propagates instability all the way down to the wrist through that interosseous membrane disruption.
That really paints a picture. Mechanism is usually a fall into the outstretched hand, right? Axial load.
Typically, yes. An axial compressive force through the forearm with the elbow extended. High-energy falls are common. But here's a fascinating point the notes bring up about the sequence of injury, based on some high-speed video analysis in cadavers.
Oh, what did they find? I always assumed the radial head breaks first, then everything else gives way.
Well, this research suggests it might actually happen the other way around. The initial event could be a transverse force, causing radial horner displacement and tearing the interosseous membrane first. Then, with the membrane gone, The continued axial load causes the radial head to fracture against the capitellum.
No way. The membrane goes first.
It's a possibility suggested by that biomechanical data. It really emphasizes how central that interosseous membrane is to forearm stability. It's not just the bones.
Mind blown slightly. Okay, so if you diagnose an acute Essex Lopresti, how do you manage this complex mess?
It requires a multi-pronged approach, hitting all the injured parts. First, you deal with the radial head or IF if possible, but often replacement is needed given the typical comminution in these injuries. Second, you have to stabilize the unstable DRUJ. This usually means immobilizing the forearm in supination and often needs temporary K-wires or screws across the joint to hold it reduced while things heal.
Okay, radial head, then DRUJ stability. What about the membrane?
That's the third part.
Yeah.
You need to consider reconstructing or repairing the interosseous membrane, IOM, especially if there's significant longitudinal instability even after sorting the bone in DRUJ.
The IOM, the notes mention its structure.
Yeah, briefly. It describes 5 main bands or cords, but highlights the central band as the most critical one for resisting proximal migration of the radius. That's the main target if you're doing a reconstruction.
And how is that reconstruction done? What graft do they use?
A common technique described uses the pronator teres muscle tendon. You detach its proximal insertion, rotate it, and pass it through bone tunnels from the radius to the ulna, aiming to replicate the vector of that central band.
Complex stuff. Okay, what if it's a chronic Essex Lopresti, say it was missed, and the patient presents weeks or months later with wrist pain, maybe ulnar deviation, loss of rotation? How does the management change then?
The chronic situation is even trickier, and the sequence of treatment is absolutely paramount. The notes laid out very clearly. Step 1 is not the radial head. Step 1 is an ulnar shortening osteotomy.
Ulnar shortening first. Why?
Because in a chronic injury, the radius is usually migrated proximally due to the IOM failure. If you try to deal with the radial head or IOM first, the soft tissues around the radius are contracted, and you'll never get the length back properly. You have to restore the relative ulnar length first by shortening the ulna.
Okay, ulnar shortening first. Then what?
Then step 2 is reconstructing the IOM, again, usually with the pronator teres transfer. Step 3 is addressing the radial head, almost always replacement in the chronic setting, maybe even excision if replacement isn't feasible or the joint is too arthritic. And finally, step 4 is dealing with any associated TFCC pathology at the wrist. It's a staged, logical reconstruction tackling the length, the membrane, the proximal joint, and the distal joint.
That's a really important sequence to remember for chronic cases. Okay, we've gone deep into radial head fractures and that critical Essex Lopresti pattern, really drawing out those key management principles from the ortho simple notes on mokyingren.sg. It's clear how linked the elbow and wrist are. Let's shift gears now and focus on another couple of important forearm injury patterns. All right, moving on now to Monteggia fractures. What's the core definition here, and how do we classify these?
The Monteggia is defined by that specific combination. A fracture of the ulna shaft coupled with a dislocation of the radial head from the capitellum. It's the ulna fracture plus the radial head dislocation.
Got it. And the classification?
That's Beto's classification. It's based entirely on the direction the radial head is dislocated. Type 1 is anterior dislocation, the most common. Type 2 is posterior dislocation. Type 3 is lateral dislocation. And type 4 is kind of the worst of both worlds. You have fractures of both the radius and the ulna shafts, plus that proximal radial Schooner joint disruption and radial head dislocation.
Okay, Beto types, based on radial head direction. Do certain types show up more in kids versus adults?
Yes, there's a pattern. Beto type 1, the anterior one, is the classic pediatric Monteggia. You see that much more often in children. Beto type 2, the posterior dislocation, tends to be more common in adults, although overall, Monteggia injuries are less frequent in adults than kids.
And nerve injuries are a big worry here, right? Which ones are most at risk?
Definitely. The nerve most commonly implicated overall is the PIN, the posterior interosseous nerve. That's simply because of its anatomical course wrapping around the radial neck, making it vulnerable when the head dislocates.
Right, the PIN.
Ulnar nerve and median nerve injuries can happen too, but PIN is the main one. The notes specify PIN injury is more frequent with Beto types 1, anterior, and 3, lateral. The ulnar nerve is noted to be more commonly injured in the type 2 posterior dislocation pattern, which is often a flexion-type mechanism, similar to how the ulnar nerve can be injured in flexion-type supracondylar fractures in kids.
Okay, that link to flexion-type injuries makes sense for the ulnar nerve. How do we manage these acutely? Is it always surgery?
In children, non-operative treatment can be an option.
Mm.
If you can get a good close reduction of the ulnar fracture and the radial head reduces concentrically and stays reduced, then casting and supination might work.
But only if it stays reduced.
Exactly. If closed reduction fails, or if you're dealing with an adult, surgical management is generally required because these are unstable injuries.
And surgically, what's the principle? What are we fixing?
The absolute key is restoring the anatomical length and alignment of the ulnar fracture. If the ulnar fracture is simple, maybe transverse or short oblique, especially in kids, flexible intramedullary nailing might be used. But for more complex fractures, comminuted ones, or generally in adults, stable plate fixation of the ulna is the standard.
Okay, platealna.
And the principle is if you get a perfect, stable reduction of the ulna, restoring its length, the radial head dislocation will often reduce spontaneously or with just gentle pressure. Fix the ulna accurately, and the radial head usually follows.
Usually. But what if it doesn't? You've got a perfect plate on the ulna, looks great, but the radial head is still stubbornly dislocated. What's usually blocking it?
The most common culprit, according to the notes, for failure of the radial head to reduce after the ulna is fixed is interposition of the annular ligament. It can flip into the joint and physically block reduction.
Ah, the annular ligament again. Okay, let's touch on Monteggia injuries. These can be a real problem if not picked up early. What do the notes say about outcomes for chronic cases, and how do we approach managing them if they present late, say 4 weeks?
Yeah, chronic Monteggia is tough. Outcomes are really influenced by two big factors: the patient's age at the time of correction and how long it's been since the original injury. The notes cite Nakamura's 2009 study,
Okay.
which showed much better results if the correction was done within 3 years of the injury and the child was under 12 years old.
Huh.
If you treat them later than 3 years, or if the patient is older than 12, the study found a very high rate, like 88% of problems like persistent radial head subluxation or early osteoarthritis.
88%, that's stark. So early diagnosis is critical.
Hugely critical. For managing these chronic cases surgically, there's, again, a specific sequence. First, you have to restore the ulnar length and alignment. Chronic missed cases often lead to a malunion or bowing of the ulna, and sometimes the radial head itself can become dysplastic, kind of convex shape. So you might need a single-stage osteotomy of the ulna. Or if there's a lot of deformity or contracture, gradual lengthening using an external fixator might be necessary. Second step, open reduction of the radial head, clearing out any soft tissue blocks again. The annular ligament is often implicated. Third, you need to reconstruct that annular ligament to provide stability, typically using a graft like triceps fascia or palmaris longus. And fourth, you temporarily stabilize the reduced radiocapitellar joint, usually with a smooth K-wire, to protect the reconstruction while it heals.
Wow, another complex reconstruction sequence. Restore length, clear the block, rebuild the ligament, stabilize. It really emphasizes addressing the primary deformity first. Okay, let's move to our final pattern, the Galeazzi injury. How's this one defined?
The Galeazzi is essentially the mirror image of the Monteggia in some ways. It's defined as a fracture of the radius shaft, typically at the junction of the middle and distal thirds, combined with disruption or instability of the distal radial ulnar joint, DRUJ.
Radius fracture plus DRUJ injury.
Okay. It's often called a fracture of necessity because that radius fracture is almost always unstable due to the associated DRUJ problem, meaning it necessitates surgical fixation of the radius.
Right, and can you predict preoperatively, just by looking at the radius fracture, how likely the DRUJ is to be unstable?
There's a useful guide mentioned, the Radial classification, based on the fracture location relative to the wrist joint. The key measurement is 7.5 centimeters.
7.5 centimeters.
Yeah. If the radius fracture is less than 7.5 centimeters from the distal radial articular surface, it's considered highly likely to be unstable at the DRUJ, over 50% chance of instability. If the fracture is more than 7.5 centimeters proximal to the joint, it's much more likely to be stable at the DRUJ, with less than 10% instability reported. It's a handy rule of thumb.
Less than 7.5 centimeters from the wrist means watch out for the DRUJ. Makes sense. And I assume the interosseous membrane is relevant here too.
Absolutely. Just like in the Essex Lopresti, the integrity of the IOM, especially that central band, contributes significantly to DRUJ stability. A more distal radius fracture often implies greater disruption towards the distal IOM attachments.
Okay, so the primary goal in Galeazzi is getting that radius fracture fixed anatomically with the plate. But what happens after you've done that? How do you check and manage the DRUJ?
Exactly. Once the radius is perfectly fixed length, alignment, rotation restored, you must assess the DRUJ stability intraoperatively. The notes describe three possibilities based on that assessment.
Okay, what are they?
1. The DREJ feels completely stable through a full range of pronation and supination after you've fixed the radius. If that's the case, great, you don't need to do anything further for the DRJ.
Good outcome.
2. The DREJ feels stable in one position but unstable in the other. For example, it's stable in supination but subluxes in pronation. In that situation, you splint or cast the forearm in that position of stability, usually supination for about 4 to 6 weeks to let the ligaments heal.
Splint in the stable position. Got it. What's option 3?
3. The DLUJ remains grossly unstable in all positions, even after perfect radius fixation. This means significant ligamentous injury, likely involving the TFCC or distal IOM fibers. Here, you need further intervention. The options include casting and supination for 6 weeks, or proceeding with an acute TFCC repair if irreparable tear is identified, or fixing an associated unstable ulnar styloid fracture if present, or temporarily transfixing the DRUJ with pins like a radial Nora pin for several weeks.
So unstable DRUJ needs more aggressive stabilization. Makes sense. Last question on Galeazzi. If you've fixed the radius perfectly, but the DRUJ just won't reduce, it's still sitting dorsally or volarly, what soft tissue might be physically blocking it?
Similar to the radial head, soft tissue can get in the way. For the DRUJ, the most common structures noted to block reduction after the radius is fixed are the tendons of extensor carpi ulnaris, ECU, and extensor digiti quinti, EDQ.
ECU and EDQ.
Yeah. They can sometimes get caught around the ulnar head or in the joint. The surgical approach to release these, if needed, is usually a dorsal approach, made just lateral to the ulnar prominence at the wrist.
Okay, good to know what to look for if reduction is blocked. Wow, we have really covered some ground today. Radial head fractures, the super complex Essex Lopresti, then the Monteggia with its ulna focus, and finally the Galeazzi with the radius and DRUJ. It really highlights how interconnected everything is in the forearm.
It really does. What's fascinating, and what these notes bring out, is how these seemingly separate injuries are all linked by the forearm's crucial structural integrity. The two bones working together, the joints at both ends, and critically, that interosseous membrane and the surrounding ligaments like the annular ligament and TFCC. Understanding the specific pattern of bone and ligament injury is absolutely the key to managing them correctly and predicting how the patient will do. It really makes you ask, are we always paying enough attention to the soft tissues in these injuries, or just focusing on the fracture line?
That's such a great point. It definitely hammers home the need for a thorough assessment that looks beyond just the most obvious break on the x-ray. You have to consider the stability of the whole unit.
Exactly. You have to think about the longitudinal and rotational stability.
And just a reminder for everyone listening, all this incredibly detailed information was distilled for you from the Ortho Made Simple notes, which you can find on the website mokyingren.sg.
So the provocative thought maybe to leave you with is this. As you're revising these injuries for your exams, or maybe when you see your next complex forearm case in clinic, try to consciously think beyond just naming the fracture pattern. Consider the mechanism that caused it, and systematically hunt for those potential associated injuries, the IOM tear, the DRUJ instability, the nerve traction, because those are often what dictate the true stability, the treatment plan, and the ultimate long-term prognosis for the entire forearm. Don't just see the break. See the bigger picture of instability.
Fantastic advice. Keep exploring those connections. Keep asking those deeper questions.
And remember again, this deep dive was based on the Ortho Made Simple notes from the website mokyingren.sg.
Thanks so much for joining us for this deep dive. We hope breaking down these complex patterns helps solidify them in your mind and makes you feel that bit more prepared. Keep studying, keep questioning, and we'll catch you on the next one.